Today we'll be comparing the pharmacology of atropine compared to glycopyrrolate. Starting with class, atropine's class is that it's a naturally occurring tertiary amine of the muscarinic class, whereas glycopyrrolate is a synthetic quaternary amine. And this will become more important when we talk about its pharmacokinetics. In terms of the use, atropine is used for bradycardia and the countering parasympathomimetic action of anticholinesterases, such as neostigmine. It's used for organophosphate poisoning, to help dry secretions, and to dilate the pupil for ophthalmologic exams. Glycopyrrolate, on the other hand, is also used for bradycardia, to dry secretions and counter anticholinesterase action. The main contraindication for atropine is closed angle glaucoma, gastrointestinal obstruction, benign prostatic hyperplasia, and myasthenia gravis. Contraindications for glycopyrrolate are similar. The mechanism of action of atropine is that it's a competitive muscarinic antagonist with minimal nicotinic blockade. The net effect is that it essentially blocks the parasympathetic effects in the body. The mechanism of action for glycopyrrolate is similar. The presentation, atropine comes as a racemic mixture, with L-atropine being the only active form and coming in a 600 mics per mil dosage. Glycopyrrolate is presented in 200 mics per mil, and the dose for atropine is usually 600 mics given every 3 to 5 minutes to a max of 3 milligrams. Glycopyrrolate, on the other hand, is dosed 200 to 400 mics and up to a max of 1.2 milligrams. Atropine has a much faster onset, occurring less than 1 minute, with a peak effect on the heart rate occurring within 2 to 4 minutes. Glycopyrrolate, on the other hand, is slower than atropine, starting around 2 to 4 minute onset. Atropine has a much shorter duration of action, around less than 30 minutes, whereas glycopyrrolate duration can last up to 2 to 4 hours, and thus this is why it's often paired with neostigmine. In terms of pharmacokinetics, atropine has much better oral bioavailability than glycopyrrolate, and this is due to its tertiary amine structure permitting increased lipid solubility. It has a protein binding of 50%, a larger volume of distribution at 2 to 4 litres per kilogram, and crosses the blood-brain barrier and placenta due to its tertiary amine structure. It's metabolized by hepatic esterase into trophine and trophic acid. In terms of elimination, it has renal elimination of inactive metabolites, and its IV half-life is around 3 hours. In terms of the pharmacokinetics for glycopyrrolate, is poor oral bioavailability, around 5%, and this is due to its low lipid solubility due to its quaternary amine structure. Due to its quaternary amine structure, it has a charged group which prevents it moving across cell membranes. Because of this, its volume distribution is much smaller at 0.2 to 0.6 litres per kilogram and is essentially confined in the extracellular fluid. It does not cross the blood-brain barrier or the placenta. It has minimal hepatic metabolism that occurs via oxidation and hydrolysis. It is eliminated primarily in the kidney, 80% excreted unchanged, and its half-life is around 1 to 2 hours. In terms of the pharmacodynamics of atropine, it could be summarized as having a parasympatholytic effect, i.e., it stops the function of the parasympathetic system. Going head to toe, in terms of the CNS effects, it causes a central anticholinergic syndrome, such as delirium, agitation, confusion, hallucinations. In the respiratory system, it causes bronchodilation and decreased bronchial secretions. For the heart, it causes tachycardia and increased cardiac output. In the gastrointestinal system, it causes a dry mouth, decreased bowel motility, bowel sounds, and gastric secretions. It also causes urinary retention. In terms of skin, it causes decreased sweating and flushing, which is a particular concern in children, which causes pyrexia due to their loss of ability to sweat. For glycopyrrolate, the pharmacodynamics are relatively similar, the main differences being that In terms of the CNS, there are minimal CNS side effects since glycopyrrolate cannot cross the blood-brain barrier. Similar effects on the respiratory system. It has less potent action on heart rate compared to atropine, and on the other hand, it has a much stronger effect at drying secretions than atropine on the gastrointestinal system. It will also inhibit sweating and cause urinary retention. As an extra, we will look at the effects of overdose of antimuscarinic drugs, such as atropine or glycopyrrolate. They cause an anticholinergic syndrome, which can be thought of as the extremes of the above drug effects, and is often summarized with a mnemonic: mad as a hatter, red as a beet, blind as a bat, dry as a bone, hot as a hair. Mad as a hatter refers to the confusion, restlessness, seizures, and in severe cases, coma that's experienced. Red as a beet refers to the flushed skin, blind as a bat, the dilated pupils, dry as a bone, the dry skin and mucous membranes, as well as the absent sweating. Hot as a hair, the hyperpyrexia. Additionally, there's tachycardia, urinary retention, and constipation. In terms of treatment, the main antidote is physostigmine, which is a reversible anticholinesterase inhibitor. The main time physostigmine is given is when there are extreme CNS symptoms, or when hypothermia or tachycardia is unresponsive to current supportive therapies. Physostigmine works by inhibiting acetylcholinesterase, which is an enzyme that normally breaks down acetylcholine. By inhibiting this enzyme, there's a rise in acetylcholine in the synaptic cleft, which then competes with the anticholinergic drugs such as atropine. As a recap, we'll go over the main differences between atropine and glycopyrrolate. The main differences being the tertiary versus quaternary amine structure. Atropine having the much faster onset and shorter duration. Atropine having the larger volume of distribution and ability to cross blood-brain barrier and the placenta, whereas glycopyrrolate has minimal ability to cross the blood-brain barrier and smaller volume of distribution. Atropine has much wider effects on the body, whereas glycopyrrolate's effects do not permeate to the central nervous system. We also talked about the impacts of anticholinergic overdose as well as the treatment. Thanks for watching my video. Please subscribe to watch more videos like this.